Honorable panelists, respected audience, Assalamu alaikum. I am Dr. Shah Akhtarul, presenting my case entitled Life Beyond Miserable, What to Do When There Is No Hope. My patient, Mr. X, 45 years, a history of smoking and alcohol intake, and with a history of diabetes mellitus, and history of MI 3 years back, with the complaints of exertional breathlessness for 6 months, and exertional chest pain for 3 months, cough for 1 month, and history of repeated hospital admission for last 6 months. He was quite well about 6 months back. Since then, he developed shortness of breath. Initially, it was INOSA class 2. However, for the last 1 month, it became INOSA class 4. And he also gave history of orthopnea as well as paroxysmal nocturnal dyspnea. He experienced exertional chest pain for last 1 month. Chest pain is mild to moderate in intensity, retrotional constituting in nature, radiating to left shoulder arm and excited by exertion and relieved by taking rest. He also gave history of cough for last 1 month, which is dry and non-productive. On query, patient did not give history of any aggravating factors such as tree and grass, pollen, any cold air exposure, dust fumes. With the same type of complaints, patient had admitted in our hospital for several times for the last 6 months. Patient was looking at this dyspneic when we have examined the patient. On examination, pulse is 86 of it means regular. Blood pressure was 90/60 millimeter of mercury. Edema present, JBP not raised. Lungs, there is a bilateral cavitation present. On investigation, profile shows that RBS is high and also hemoglobin percent is normal, but the NT-proBNP, we see that is significantly high. And this is the ECG when he was admitted at that time, and we have found that there is a rate is about 86 beat per minute. Rhythm is regular, and QRS is about 120 millisecond. It is fragmented, and there is pathological QR present in 2-3 AVF, and also there is features of LA enlargement. And this is the ECG of a previous admission. And where we also see that this rate is about 90 and rhythm is regular. QRS is about 110 millisecond and it is fragmented QRS. And pathological QR present also here and features of LA enlargement. Chest X-ray shows the cardiomegaly and the echocardiography. And this is a 2D mode showing there is an increase the LA size. It is about 46 millimeter and EPSS is about 29 millimeter. And 2DM mode showing there is a global wall hypokinesia present and ejection fraction is about 29%. And we also done that RV function and regarding RV evaluation, the tricuspid valve S prime shows that it is about 5 centimeter per second and it is TAP C is about 10.7. And there is mild tear present. And there is also there is a mild to moderate mitral degradation also present. And the final echo findings there, the global wall hypokinesia, dilated LA and LV, severe LV systolic dysfunction, RV systolic dysfunction, MR moderate, and TR mild. And with that, we have started the treatment at the time of admission, and we have given all the treatment modalities like ARNI, beta blockers, the 4 pillars of drugs, empagliflozin, and also we have started the vericiguat at the time. And also patient has a control for diabetes, we have also insulin. But patient was still symptomatic despite optimal medical management. So further was planned that what can I do? So we have done the cardiac MRI. The cardiac MRI showing that the LV EDD is 72 millimeter dilated with moderate to severe LV systolic dysfunction and dilated left atrium, no evidence of thrombus. And the interpretation was that dilated cardiomyopathy, dilated LA and LV. CMRI evidence shows viable myocardium present in the LCX and the RCA territory, but non-viable myocardium in distal LAD territory. So we have think this is a case of advanced heart failure. So according to the ESC 2020-21 guidelines, the criteria for definition of advanced heart failure is the severe and persistent symptoms of heart failure, INOSA class 3 or advanced or 4, and severe cardiac dysfunction, LV ejection fraction less than 30%. And also there is a present that the history of hospitalization in the last 12 months require repeated episodes of admission. And the discussion is for this, that what we can do for our patient, because the further modalities of treatment is now so much costly. So we are here to know the exact treatment modalities about these patients. So what can I do for our patient?